Dear audience, Assalamu alaikum. I am Professor Shamsud. I am inviting all the audience to attend my third lecture on hematology. Today, I will discuss about iron deficiency anemia. Dear audience, before going to discuss about iron deficiency anemia, we have to recapitulate anemia. What is anemia? Pale coloration of skin and sclera. Skin and sclera due to reduction of hemoglobin below the normal level as per age and sex is called anemia. Dear audience, it is reduction of hemoglobin per unit volume of blood as per age and sex that leads to pale coloration of skin, sclera and mucosa. Dear audience, suppose X gram of hemoglobin per deciliter in certain age and sex. If at that age and in sex the hemoglobin becomes X minus some, and this is the reduction of hemoglobin per unit volume of blood, and by definition it is anemia. Dear audience, we can classify anemia on the basis of morphological type and on the basis of etiology. We know morphologically based on hematological absolute values, that is based on red cell indices. Morphologically, anemia three types. Morphological type of anemia based on hematological absolute values. That is based on red cell indices. Three types. One is microcytic, hypochromic anemia. Another is normocytic, normochromic anemia, and last one is macrocytic anemia. So morphological, you get three types: microcytic, hypochromic, normocytic, normochromic, and macrocytic anemia. In first one, MCB, MCH, MCHC, MCV, MCH, and MCHC. You know, these are the hematological absolute values. These absolute values is decreased in first type, in microcytic hypochromic anemia, and in normocytic normochromic anemia the absolute values remain unchanged, but in macrocytic anemia MCB is increased. Now come to, what are the causes or what are the examples of microcytic hypochromic anemia? Microcytic hypochromic anemia we get in iron deficiency. So iron deficiency anemia is one of the microcytic hypochromic anemia. Then thalassemia, Morphologically is microcytic hypochromic anemia, then sideroblastic anemia, is an example of microcytic hypochromic anemia, and anemia in any chronic diseases. And anemia in any chronic diseases, it is nothing but microcytic hypochromic anemia. Anemia in any chronic disease. So these are the different causes of microcytic hypochromic anemia. Today come to iron deficiency anemia. Today come to iron deficiency anemia. If we want to define what is iron deficiency anemia, we can say it is a one type of microcytic hypochromic anemia due to iron deficiency. Anemia that results from iron deficiency, and that is morphologically microcytic and hypochromic, that anemia is called iron deficiency anemia. Dear audience, now come to what are the causes of iron deficiency anemia. Causes of iron deficiency. What are the causes of iron deficiency that are associated with anemia? The causes: number one, increased physiological demand of iron. Number two, inadequate intake of iron. And number three, pathological loss of iron. So these are three important causes of iron deficiency. Number one, increased physiological demand of iron. Number two, inadequate intake of iron. And number three, pathological loss of iron from body. First come to increased physiological demand. First come to increased physiological demand. Dear audience, in growing child, there is increased demand of iron. So increased the demand of iron as in growing child. Why in growing child there is increased physiological demand of iron? It is due to number one, progressive increase in number of RBC. You know, RBC contains hemoglobin and hemoglobin contains iron. So in growing child there is progressive increased number of RBC. So in growing child there is increased demand of iron. If we fail to meet up the increased demand, there will be iron deficiency anemia. Number one due to this. Number two, due to increase in myoglobin. Dear audience, you know our skeletal muscle contains myoglobin, and this myoglobin contains iron. So during growing child there is increase in myoglobin. So for synthesis of myoglobin there is increased demand of iron. Number three, increase in cytochrome enzymes. Dear audience, you know cytochrome enzymes contains iron. So increase in amount of cytochrome enzymes in growing child leads increased iron. If we fail to fulfill the demand, there will be iron deficiency anemia. So increased physiological demand in growing child. Again, increased physiological demand in female reproductive life. So increased physiological demand of iron in reproductive life, of female. Why in reproductive life of female there is increased demand? It is due to number 1, menstruation. Number 2, pregnancy. Number 3, persuasion. And number 3, lactation. All are the physiology, and in this physiology there is increased demand of iron. If we fulfill if we fail to fulfill the demand in such physiological conditions, there will be iron deficiency anemia. So number 1, increased physiological demand. Now come to inadequate intake of iron. Inadequate iron intake. What are the causes of inadequate iron intake? This inadequate iron intake may be due to nutritional deficiency, or this inadequate intake of iron may be due to impaired iron absorption. So nutritional deficiency and impaired iron absorption is associated with inadequate intake of iron. Now come to nutritional deficiency that are associated with inadequate intake of iron. This nutritional deficiency may occur in child or in infant due to dietary insufficiency. So dietary insufficiency in infant is associated with iron deficiency. Again, so nutritional deficiency in infant or child due to dietary insufficiency. Again, food dislikes or anorexia. Food dislikes or anorexia during pregnancy is associated with iron deficiency. Because if there is food dislikes or anorexia during pregnancy, she will not take sufficient amount of food, so there will be iron deficiency. This is the inadequate intake of iron. Now come to impaired iron absorption, how it causes inadequate intake. Now come to impaired iron absorption. Impaired iron absorption. Dear audience, you know this is the esophagus, and this is the stomach, you know. This is the intestine, you know, duodenum. You know, iron first comes in the stomach. If iron comes in the stomach as ferric form, this ferric form is converted to ferrous form. with the help of hydrochloric acid. So if anybody is associated with gastrectomy, either total gastrectomy or partial gastrectomy, there will be impaired iron absorption. So causes of impaired iron absorption is gastrectomy, first gastrectomy. Another cause of impaired iron absorption is gastrojejunostomy. Gastrojejunostomy. And another cause of impaired iron absorption is tropical sprue. Tropical sprue. So these are the different causes of impaired iron absorption that is associated with iron deficiency anemia. Now come to pathological loss of iron. Now come to pathological loss of iron. What it means? It means the individual is taking sufficient iron. There is sufficient iron within the body, but there are some pathologies, there are some diseases. Due to some sorts of diseases, iron is losing from the body, and that is associated with iron deficiency anemia. What are the different causes of pathological loss of iron? What are the causes? Bleeding peptic ulcer. Bleeding peptic ulcer. If anybody suffers from gastric ulcer in the stomach, ulcer, if it bleeds, it will lead to iron loss. Then hookworm infestation. Ankle stomadurinally. If anybody suffers from hookworm infestation by ankle stomadurinally, what will happen? In the colon, the colonic mucosa, if this is the ankle stomadurinally or there is the hookworm, it will suck blood from the intestine. As it sucks blood, there is loss of blood, loss of iron. Again, after sucking, it moves from the area and the point remain open, and from the open point there is continuous bleeding, so there is pathological loss of iron. Then hemorrhoid, bleeding hemorrhoid. You know, hemorrhoid, that it is nothing but piles. If there is bleeding regularly, there will be loss of iron and it will lead to iron deficiency anemia. Then carcinoma of stomach. Cancer or carcinoma of stomach, it will lead to blood loss, pathological iron loss. Again, in female menorrhagia. So these are the important causes of pathological loss of iron. Now come to, if anybody suffers from iron deficiency anemia, what may be the clinical presentations? Dear audience, if anybody suffers from anemia, whatever may be the type of anemia, whatever may be the cause of anemia, there are some common symptoms. So in iron deficiency anemia, you will get the common symptoms. In addition to common symptoms, there are some symptoms and signs that are present in iron deficiency anemia. Now come to clinical presentation. Now come to clinical presentation of iron deficiency anemia. The first and foremost presentation, symptoms of anemia. There are symptoms of anemia that is found in all anemias. You will get here also. What are those? Pale coloration or pallor, effort intolerance, palpitation, fatigue. So these are the symptoms of anemia. Besides this, you will get, in case of iron deficiency anemia, epithelial changes. Epithelial changes. The epithelial changes is predominantly found in the nail bed. So due to epithelial changes, the nail bed become thin. The nail bed become thin. Thinning of a thin nail bed. Then there will be ridging, longitudinal ridging in the nail bed. Longitudinal ridge. Longitudinal ridging in nail bed. And gradually the nail bed become thin, longitudinal ridging, and ultimately due to thinning, ultimately the convexity of the nail bed become flattened. So flattening of nail bed. Flattening of nail bed. So these are the epithelial changes. Before that, patient may develop Palmer-Vinson syndrome. Palmer-Vinson syndrome. Dear audience, you know syndrome is nothing but symptom complexes. So in Palmer-Vinson syndrome, what we will get? Here we get epithelial change. Here we will get epithelial change. We get dysphagia and we get glossitis. We get glossitis. So these are the clinical presentation of iron deficiency anemia. So now come to how iron deficiency anemia is diagnosed in laboratory. That is laboratory diagnosis of iron deficiency anemia. Now come to laboratory diagnosis of iron deficiency anemia. Nowadays, I have told you iron deficiency anemia is one of the type of microcytic hypochromic anemia where MCB, MCH, MCHC all are decreased or reduced. So, how we can diagnose in laboratory? Number one, blood examination. Some biochemical tests. Then bone marrow examination. First come to blood examination. First come to blood examination. First we have to do hemoglobin estimation. As it is anemia, it will be reduced. Then we have to do hematological absolute values. Hematological absolute values, that is MCV, MCH and MCHC, all three are decreased. Then we have to do ESR, it is normal. We have to do total leukocyte count, normal count. We have to do differential leukocyte count, DLC, normal, DLC. We have to do peripheral blood film, PBF, it is important for iron deficiency anemia. First, in PBF, we know in PBF we have to see RBC series, WBC series and platelet. Now come to first RBC series. The cells of RBC series show microcytosis and hypochromia. That is, cells are microcytic and hypochromic. And in addition to this microcytic and hypochromic red cell, we will get pencil-form cells. Pencil-form cells present. Dear audience, you know, normal RBC is biconcave disc, and in the periphery there is maximum concentration of hemoglobin, and in the central third is about pale. This is normal RBC. So in case of iron deficiency anemia, the size of RBC will be reduced. Size of RBC will be reduced, and there will be hypochromia. Size reduced means microcytic. Hypochromia, how it indicates, there is the central 1/3 pale will be increased. In case normal RBC, central 1/3 is pale, but in case of iron deficiency anemia, more than 1/3 central part will be pale. It indicates hypochromia. In addition to this, we will get elongated pencil from RBC. This is the pencil from RBC. It is the characteristic feature of iron deficiency anemia in peripheral blood film. So in peripheral blood film, RBC series. Now come to WBC series. Cells are mature with normal count and distribution. What it means? The count of WBC is within normal. It is within 4,000 to 11,000 per cubic millimeter of blood, and distribution is normal. It indicates it is not a disease of WBC, rather it is a disease of RBC. Then platelet. You know, platelet normal count is 1.5 lakh to 4.5 lakh or more per cubic millimeter of blood. The peripheral blood film shows adequate number of platelet. That means it is not a disease of platelet. Platelets in adequate number. Send adequate number in the film. So this is the peripheral blood film examination in iron deficiency anemia. Now come to biochemical test. What biochemical test will do? Dear audience, it is a case of iron deficiency anemia. It is a case of iron deficiency anemia. So first we have to know what about the serum iron level. Serum iron will be decreased. Then iron binding capacity. Iron binding capacity will be increased. Definitely there is iron binding capacity of plasma. If iron is decreased, binding capacity will be increased. Now come to serum ferritin. Serum ferritin will be decreased. Now come to percentage saturation of iron binding protein. Percentage saturation of iron binding protein. Dear audience, you know in our plasma there is a protein. That protein binds with iron. This is called iron binding protein. As in the plasma iron is decreased, so percentage saturation of iron binding protein will be increased. It will be increased. Sorry, it will be decreased. So this is the biochemical test for iron deficiency anemia. Now come to bone marrow. Dear audience, you know iron is deposited in the bone marrow. In case of iron deficiency anemia, we have to know what about the iron, strainable iron in bone marrow. As iron is stored in bone marrow, in iron deficiency anemia there will be definitely shortage of iron in the storage of the bone marrow. So if we stain the bone marrow by Prussian blue reaction for the stainable iron, we will see stainable iron will be diminished. So Prussian blue reaction is done for stainable iron in bone marrow. It is a stain. Prussian blue reaction is done for stainable iron in bone marrow. If we do it, the stainable iron in bone marrow in case of iron deficiency anemia will be diminished. So stainable iron in bone marrow will be diminished. So this is the bone marrow findings, and this is all about the laboratory diagnosis of iron deficiency anemia. Dear audience, I have told you it is one of the microcytic hypochromic anemia. So what is the differential diagnosis of iron deficiency anemia? Now come to differential diagnosis. Of iron deficiency anemia. The conditions or the anemias where we will get microcytic hypochromic anemia, that are the differential diagnosis of iron deficiency anemia. So one is thalassemia, another is sideroblastic anemia, another is anemia in any chronic diseases. So these are the differential diagnosis of iron deficiency anemia when we get microcytic hypochromic RBC. This is all about the iron deficiency anemia. Today up to this, thanks all.